Once a patient arrives in the emergency room, the golden hour of opportunity for confirming the diagnosis and treating the stroke begins. A coordinated rapid response is crucial. Each member of the stroke team plays a role, including personnel from the emergency department, laboratory, radiology, and neurology. We've got a 68-year-old male, possible code stroke. Let's implement standing orders for the labs and notify radiology to clear their table. Let's get IV access started, and I want this patient NPO until we can get swallowing screen done.
Got it.
The National Institutes of Health recommends a precise sequence of time intervals that enable eligible stroke patients presenting to the emergency room to receive Activase TPA within 60 minutes from door to needle. Beginning in the emergency room, the patient with a possible acute ischemic stroke should receive an initial exam and evaluation of history within 10 minutes of arrival. Obtaining an accurate patient weight is crucial, as dosing for Activase is weight-based, and this information can expedite treatment of eligible patients once a diagnosis is made. The National Institutes of Health Stroke Scale is a valuable tool for making an initial assessment of stroke symptoms.
What time did you notice something was wrong?
Well, the show was on television, so I knew that it was after 4 o'clock. About 20 minutes after 4 o'clock.
After this initial patient assessment, it is critical to perform diagnostic tests to rule out a bleed. A non-contrast computed tomography, or CT scan, of the brain should be completed within 25 minutes of the patient's arrival at the emergency room. This scan should be evaluated within 20 minutes. This scan is necessary to rule out intracranial hemorrhage. A hospital can provide Activase therapy even without on-site access to a stroke specialist. With appropriate systems in place, telemedicine may enable a physician in one hospital to consult with a stroke specialist in another using an audio and video link in order to diagnose, evaluate, and recommend treatment for a stroke patient. Even a telephone consultation may be sufficient to confirm the diagnosis, determine patient eligibility, and if appropriate, initiate treatment with Activase. Not all patients are eligible for thrombolytics. Contraindications to Activase therapy include evidence of having had an intracranial hemorrhage or suspicion of a subarachnoid hemorrhage on pretreatment evaluation, history of intracranial or intraspinal surgery, serious head trauma or stroke within the previous 3 months, intracranial hemorrhage, or uncontrolled hypertension at the time of treatment. If the patient meets all the criteria for administration of Activase, but their blood pressure is too high, appropriate treatment must be given to lower blood pressure before Activase may be administered. Patients should not receive Activase if they have had a seizure at the onset of stroke, active internal bleeding, an intracranial neoplasm, arteriovenous malformation or aneurysm, or a known bleeding diathesis or other contraindications. See the contraindications section of the package insert and the safety and indication information at the beginning and end of this program for more information. The most common complication encountered during Activase treatment is bleeding, including potentially fatal intracranial bleeding. The type of bleeding associated with thrombolytic therapy can be divided into 2 broad categories: internal bleeding, involving intracranial and retroperitoneal sites, or the gastrointestinal, genitourinary, or respiratory tract, and superficial or surface bleeding, observed mainly at invaded or disturbed sites. Should serious bleeding occur, that is bleeding that is not controlled by local pressure, the infusion of Activase should be ended immediately. If the patient meets all eligibility requirements, intravenous Activase may be administered and is the standard treatment for eligible patients with acute ischemic stroke.